going back, the DSRIP dollars, $6.4 billion over 5 years. The target is 25% reduction of hospitalization, or avoiding that many. What is the starting point on it? Are we using a certain date certain, or how is that starting point of how are we going to know we've made the 25% reduction?
Sure. So it's a 25% reduction in avoidable hospital use, just to be clear that it's not just a 25% reduction in all hospital use. Most hospital use is appropriate. People are using care. But what we're really trying to do is target when someone is going into an emergency room, going into a hospital, either on an initial admission or a readmission, when if the delivery system had done a better job, that would not have occurred. It's usually as a result of an overall failure of the delivery system to meet the needs of the person in the most appropriate setting. And so that's really what we're targeting. So in terms of 25% reduction, what does that mean? So each of the 25 performing provider systems will have its current performance established and establish a baseline. And then the goal is that each and every year we want to see a reduction in avoidable hospital use. Now, payments to the performing provider systems that will be impacted upon their success or failure in those measures really start to make a meaningful difference starting in year 3. So in years 3, 4, and 5. So it gives each performing provider system an opportunity to stand up the infrastructure in order to implement their projects so they can actually achieve the results. But it's basically each performing provider system is held accountable based on making improvements compared to where they start, which is where they are today.
And so the targeted time for the 25% is?
The full 5 years.
The full 5 years. Back to a question that you, or a point you had made earlier. 1.9 million people have signed up through the exchange. 1.4 million, you said, were on Medicaid. You also said how many had not enrolled before or not been in health care before. I missed that number that you gave.
80% of the 1.9 plus million had reported 80%. No coverage at the time of enrollment.
Thank you. So just following up with a few of those numbers, do we know how many people had insurance, but then with a non-qualifying plan, who then have been picked up? Do we know those numbers?
I can get back to you with those numbers.
My sense would be, as we look at the overall success, maybe they ought to be pulled out of that. In other words, they had insurance, then they didn't because of the action we took. And so we wouldn't know then, if we don't know exactly how many we had, we don't know what percent of those went to private plans versus Medicaid. I would appreciate, as you look at that, to enroll before. Do we know, again, a few questions about this, employer-paid health care today versus pre-Affordable Care Act? So do we have more people getting private health care or more people or fewer today? Do we know those numbers?
Right. So we do track, and nationally it's tracked, the percent of total health insurance that is employer-based, so people receive it through their employer. We have been in a pretty steady decline nationally and here in New York as well in terms of employer-sponsored insurance. That accelerated with the Great Recession. A lot of jobs were lost, obviously, and not all the jobs that were created offered the same kind of health insurance benefits of the past. So it's trying to separate out the impact of the Affordable Care Act from what is otherwise a general decline in employer-sponsored insurance is a challenge to do. But I think what makes us feel that we're doing a pretty good job of making sure that we're targeting the initiative at who needs to get targeted is that 80% number, that the vast majority of people who are coming to the exchange really don't have a health insurance product. Maybe they did prior to job change, and unfortunately we've lost manufacturing jobs and others that often provided health insurance benefits. But it is one of those things that we look at because we certainly do not want to have the exchange crowd out good employer-sponsored insurance. And I think we'll have to watch continuing, particularly the small group market over time, to see how it performs. We're hopeful that with the shop, that we will create a more robust small group market than what was the case prior to the Affordable Care Act.
Kind of. The next thing I guess I'd like to, we're getting pretty close. We're under the cap this year that we've imposed for the state on Medicaid spending. But we're getting perilously close, I think, to that. And there's a concern that we're going to see some significant increases in the future. Do we have projections on that? Are we confident we can stay within the cap that we've self-imposed in the state?
Well, we've been living under the global cap for 4 years, so we spend a tremendous amount of time and energy trying to project how we will spend money. It is a very large and complex program with lots of puts and takes in it, but we know a lot more today about how the program functions than we did 4 years ago, and we employ that knowledge and understanding every day to honing our efforts.
And I'm sorry, are there any Medicaid cost-saving measures that we're proposing now or looking at that are going to help in that process?
Absolutely. So in this budget, as in the past budgets, we're proposing a balanced scorecard, meaning that we propose investments, things like some of the things we talked about, but also savings initiatives that are designed to generate a rate of return and help control costs in the program. So we feel next year that we have presented to the legislature a balanced Medicaid program, and one that will lead to greater efficiencies. To give you a sense of the success to date, we have reduced per recipient spending in New York State Medicaid down to 2003 levels. That is a 10% reduction on a per recipient basis. So in an era where costs in healthcare generally tend to grow in some years at double-digit % rates, or certainly in single-digit rates, we have actually been able to reduce overall Medicaid spending. If you look at total spending in Medicaid, basically it's been flat throughout the MRT period, yet at the same time we've increased enrollment by 1.1 million people. We feel that we have a strong track record, but we have to continue to be vigilant in terms of managing this big program. We're a third of the state budget, and if we have a budgetary problem, it's a budgetary problem for the entire state. So, but we feel that the budget that's proposed lives within its means and the amount that the global cap would otherwise have given us under state statute.
Thank you.